also from me. What I will talk about in my presentation here is, first of all, a few words on the prevalence and consequence of diabetes. We all know the problem of diabetes, but let's have a look at it. And then diabetic kidney disease, which is a serious problem in Asia, and especially in South Asia. After that, I will address the effect of glucose lowering on diabetic late complications. We tend to forget the importance of glucose lowering because it has been so difficult to implement the optimal glucose control. After that, I will switch to the new anti-diabetic medication, especially linagliptin, which is a unique DPP-4 inhibitor, and the topic, actually the focus on my talk today. And at the end, I will talk about, by the use of linagliptin, are we able to reduce the presence of albuminuria? And I will give you some data from the Marlena trial. What you will see from the next slide is type 2 diabetes is increasingly prevalent, and you can see that today we have about 387 million people with diabetes, but the projection for 2035 is nearly 600 million. Just for your information, back in 1985, there were 30 million people with diabetes. Year 2000, there were 160 million. And at the year 2000, the projection for 2035 was 370 million. And we have already achieved that. So we have reached that number. So type 2 diabetes is increasingly prevalent, and it's actually increasing with epidemic proportions. On the right-hand side of the slide, you can see type 2 diabetes doubles the risk of diabetes, of death, and this is due to cardiovascular death. The data in the next slide, you can see here, diabetes doubles the risk of vascular events, not only coronary heart disease, but also cerebral vascular disease. So anytime you have a patient with diabetes in front of you, you will see that diabetes in itself doubles the risk of vascular events in this patient. And if you then look at the consequences of having diabetes, in the middle, you can see that a patient that is 6 years old living with diabetes, this patient has about 6 years shorter life expectancy. But if the patient has suffered a myocardial infarction, the life expectancy is actually 12 years shorter. So this is a serious complication. So if diabetes is that serious, what will then happen if the patient with type 2 diabetes also presents him or herself with diabetic kidney disease, which I already said is a common and serious problem in Asia. So this slide shows that diabetic kidney disease these are data from the US, but it shows very importantly that the mortality risk is increasingly prevalent or increasing when you have all the signs of diabetic kidney disease. On the right-hand side, we have albuminuria and reduced eGFR, and you can see many-fold increased risk of premature mortality. And you can see that already, if there are presence of albuminuria, which is an early sign of diabetic kidney disease, or an impaired glomerular filtration rate, you can see that already many-fold increased risk of premature mortality. So diabetic kidney disease is a serious complication. The next slide will show that it's not only premature mortality. This slide from the advanced trial shows on the right-hand side, where you can see we go from 90 through 90 to 60 to 90, below 60. This is the eGFR. And on the x-axis, we have macro, micro, normal. That basically means that you go from the right to the left, more albumin is leaking into the urine. So you can see that the more albumin that leaks into the urine and the less the kidneys function, the more likely the patients are to face a cardiovascular event, stroke, or a myocardial infarction. And the next slide shows the red bars are patients with diabetes. And you can see here that the risk of a myocardial infarction, stroke, peripheral vascular disease, and death are increased by diabetes. But the black bars are those patients that not only have type 2 diabetes, but they also have diabetic kidney disease. And you can see that the risk of all these events will double. So diabetic kidney disease is a serious complication, although diabetes in itself is a serious complication. So I already said that diabetic kidney disease is common in Asia, and especially in South Asia. If you go out and screen for diabetic kidney disease worldwide, as done in this demand study, these are now the data show for Asia, you can see that 56%, more than every second one, will have albuminuria, so increased albumin-creatinine ratio. And about 22% will have a reduced eGFR, meaning that the kidney function is reduced. So if we put these together, more than 65% of people having type 2 diabetes will also show signs of diabetic kidney disease. And as I told you, that is associated with a manifold increased risk of any of the events that I showed you: myocardial infarction, stroke, peripheral vascular disease, and premature death. So we need to do something. And what can we do? So let me now show you a few slides on the effect of glucose lowering, because when we treat patients with type 2 diabetes, of course, what we can do is to treat the glucose. And the next slide shows data from the UK-PDS, which is one of the landmark trials in newly diagnosed diabetic patients. This was done a long time ago in the UK. And you can see that the red bars here are effects of glucose lowering on the microvascular complications. The blue ones are effects on the macrovascular complications. And what this shows is that a 0.9% reduction in hemoglobin A1C at the closeout of the UK-PDS after 9-10 years showed a wonderful effect on the microvascular side, but not so much on the macrovascular side. A more recent study was the ADVANCE trial, again showing on the right-hand side here that the microvascular events were reduced by intensive glycemic control. So good glycemic control is important. The problem with, you can see on this slide, is again that the effect on the macrovascular side was less impressive. But if you look at all the glucose lowering trials, as shown in this slide, you can see we have a lot of glucose lowering trials like the ACCORD, ADVANCE, BADT, Kumamoto, UK-PDS. And what you can see here, intensive glucose control reduces the risk of microalbuminuria by 14%. And also it shows that you can reduce the risk of macroalbuminuria by 26%. More importantly, intensive glucose control reduces the risk of ending up on dialysis by 46%. So this means that intensive, good glycemic, optimal glycemic control reduces the risk of ending up on dialysis, ending up with macroalbuminuria or microalbuminuria. So intensive glucose control is important. So then the question is, why have not all patients been given optimal glucose control? And this is how the problem is highlighted in this slide. The red bar means patients with type 2 diabetes. And on the y-axis, you can see the risk of severe hypoglycemia. So the mode of action of the treatments we are using today, insulin, sulfonylureas, they run the risk of hypoglycemia by using these medications. Now, the black bar are those patients with type 2 diabetes and diabetic kidney disease. And you can see that they have a double risk of severe hypoglycemia. The question is why? Yes, because with renal impairment, you will have less insulin excreted by the kidneys, you will have more insulin circulating, and you will also have less compensatory gluconeogenesis, because 30 to 35% of the glucose produced during fasting comes from the kidneys. So if you have renal impairment, you have more insulin circulating and you have less compensatory gluconeogenesis. So these people with diabetic kidney disease, they run the risk of severe hypoglycemia. And this is also very much highlighted in this slide, data from the ACCORD trial. ACCORD was a trial of glucose lowering where they tried to get down in the hemoglobin A1C down to below 7%, even down to 6.5%. And the question asked was, can we reduce macrovascular disease by going for intensive, aggressive, optimal glucose control? And you can see there is no consistent benefit, macrovascular benefit, but there was an increased all-cause and cardiovascular mortality. And this made doctors feel that there's no idea of trying to achieve optimal aggressive glucose control because you actually do more harm than good for the patients. In the next slide, you can see that the risk of hypoglycemia, so low blood glucose in the VADT and the ACCORD was increased dramatically, less so in the advanced because advanced trial was a more mild treatment. But you can see that hypoglycemia was also associated with increased cardiovascular events in the VADT. So this just tells us that if you strive for intensive glucose control with the current medications, you run the risk of severe hypoglycemia. And that has made doctors less active, or let's say reluctant, to strive for optimal glucose control. And then if you ask the question, who are the patients that will run the risk of severe hypoglycemia? Yes, it's the elderly. And if you look at the next generation type 2 diabetic patients in the world, those will be the above 65-year-olds. And these are also the patients that have signs of renal dysfunction. So this is the reason why aggressive, optimal, intensive glycemic control has not been on the agenda for many doctors. On the other hand, as I told you, good glycemic control, intensive glycemic control reduces the risk of diabetic kidney disease. So what can we do in the future? Now we are in a wonderful situation because there are now many newer, new generation anti-diabetic medications. And this is just a list. The DPP-4 inhibitors, one example is linagliptin that I will talk about today. We also have GLP-1 agonists. One example is liraglutide that I will show one slide later on. And then we have the SGLT2 inhibitors, for instance, empagliflozin. All these newer anti-diabetic medications, they have one thing in common. And what they have in common is that these newer anti-diabetic medications do not by themselves cause severe hypoglycemia, only when they're combined with sulfonylureas, insulin, or glinides. So the newer ones do not cause by themselves hypoglycemia, and this is very important. So let me now focus on one of the DPP-4 inhibitors, and that is linagliptin. Linagliptin is a unique DPP-4 inhibitor in the sense that compared with the other DPP-4 inhibitors, sitagliptin, vildagliptin, saxagliptin, or alogliptin, that are on the market in many countries. I don't know which ones are the market in India, but you guys know that. But here you can see that they are different. Linagliptin is different from the others because linagliptin is not excreted by the kidneys, but the other ones are excreted by the kidneys. And if you look at the next slide, this is also highlighted here. So linagliptin is not accumulated in the plasma or serum in renal impairment. So you can see in mild, moderate, or severe renal impairment, there's no accumulation, nor is that accumulation in dialysis. But if you look at other medications like sitagliptin and also vildagliptin, you can see that in severe renal impairment and also in end-stage renal disease, you can see that there is accumulation of the drug. So this is where the drugs are different. The good news with sitagliptin is that with linagliptin is that you can use that medication without a dose adjustment. If you are using vildagliptin or sitagliptin, you have to adjust the dose in order to make sure that you are not seeing accumulation of drug in patients with renal impairment. But the good news with linagliptin is that you can actually use it without dose adjustment. What about patients with hepatic impairment? Now I see that's a problem with this slide. You should see A and B in the beginning, two yellow bars in the beginning that about the same height as C. So this is just telling us that even if you have hepatic impairment, there is absolutely no accumulation whatsoever with linagliptin. So not only in renal impairment, but also in hepatic impairment, you can use linagliptin without dose adjustment. And this is important. It's easy when you're treating the patients. The question is linagliptin and the DPP-4 inhibitors effective? Yes, they are. This slide shows that linagliptin on the left, then Saxa, Sita, and vildagliptin. You can see that the effect is very similar with all of these medications. And then the question is, if you are using a DPP-4 inhibitor, linagliptin, as shown here, is the effect sustained? Yes, it is. So you can expect the effect to stay on for a long time. What about in combination with other drugs? This slide shows that if you use linagliptin in monotherapy, you add on to metformin or add on to sulfonylurea in the middle, or add on to sulfonylureas and metformin, or add on to insulin, you can see that the same effect is seen at any combination or even in monotherapy. The red bars is very interesting, and this is very good news for you guys, because in Asia, these are not done in South Asian patients, but this is done, for instance, for monotherapy in Japanese, the triple combination Korean patients, and insulin. There might be some also South Asians, but you can see that the effect of linagliptin, if anything, seems to be even more stronger in Asia. What about in renal impairment? Is the effect of linagliptin the same? This slide shows that exactly the same effect if you have no signs of renal impairment or you have mild or moderate renal impairment. So linagliptin works well. No dose adjustment. You can add on to any of the other anti-diabetic medications, and you can use at any stage of renal impairment. So let me now ask an important question, because I told you that diabetic kidney disease and diabetes, they lead to a lot of complications, an increased risk of premature mortality, cardiovascular events. And if you have diabetic kidney disease, this risk is doubled. So we asked the question a few years ago, can linagliptin reduce albuminuria, which is one of the early signs of diabetic kidney disease? And of course, if it reduces albuminuria, you can draw the conclusion that that will prevent diabetic kidney complications. So we put together in a pooled analysis data from 4 different studies, and these patients had either microalbuminuria or macroalbuminuria, and most of them had normal renal function or mildly reduced renal function. But most important fact was that they all had stable RAS blockade, so ACE inhibitors or angiotensin receptor blockers. So the data I'm showing you, the pooled analysis shown here, is that in the middle you have the eGFR, so 50%, more than 50% had normal renal function, and about 30% had mild renal impairment. So very few had moderate renal impairment, only 10%. And if you look at the albumin excretion rate, 90% had microalbuminuria, only 10% had macroalbuminuria. So we are dealing now, next slide please, we are dealing with a population of type 2 diabetic patients that have near normal or mildly reduced kidney function, and most of them microalbuminuria. And this slide shows in the pooled analysis, unexpectedly, linagliptin reduced albuminuria by 28%. And this was an astonishing result, because this was on standard care, stable RAS blockade. Now, please keep in mind, pooled analysis or meta-analysis, they can only generate the hypothesis, there are no proof. So we need to prove that linagliptin reduces albuminuria. And we set out to do that. And that study was called the Marlina, and I was lucky enough to be the principal investigator of this trial. So in the Marlina trial, we were set out to prove the hypothesis that were generated by the pooled analysis. So the aim was to prospectively investigate glycemic and renal effects of linagliptin in patients with type 2 diabetes with poor glycemic control and albuminuria receiving, importantly, ACE inhibitors or angiotensin receptor blockers. And the next slide shows the design of the trial. So linagliptin, 5 milligram per day versus placebo, and you can see that was a 24-week trial, preceded by a placebo run-in and followed by a follow-up period. And then if you look at the patients that were involved, so if you look at this rather busy slide, what you can see here is that basically same kind of patients that I showed you in the pooled analysis, apart from one difference. And that difference is that in the Marlina trial, there were more Asian patients than in the pooled analysis. Otherwise, we talk about very similar patients, type 2 diabetic patients with normal or mildly reduced renal function, and 90% had microbinuria, only 10% macrobinuria. Did we see in the trial? This is just to highlight again on the left-hand side that the majority had normal kidney function, on the right-hand side, the majority had microbinuria. So also importantly, of course, to see how were they treated with RAS blockade, because this is always important. And here you can see that 2/3 had angiotensin receptor blockers and 1/3 ACE inhibitors. But now we have to keep in mind that patients with diabetic kidney disease, they should always be treated with RAS blockade. So we asked the question, what can we do if we give them linagliptin on top of that? So the Marlina trial had one primary endpoint, and the primary endpoint was reduction A1C. You can argue why was that the primary endpoint and not the reduction in albuminuria. This is how studies have to be done, because the indication for linagliptin is glucose lowering. So you have to have the primary endpoint is the lowering of A1C. And you can see 0.6% reduction in A1C, exactly the same effect that we have always seen. And you can see it's sustained over 24 weeks here. And if you look at the effect on A1C in different sub-analyses, now I see that the line from 0 here in the middle is missing, but you can see that everything is basically on the left-hand side of the line. So the effect on A1C is the same, irrespective of albuminuria, renal function, IOation, or Caucasian. So also what we can see from this slide is that more patients achieved an A1C below 7% on linagliptin than on placebo. Now, the secondary endpoint in this trial was the one that we were interested in. So the question was, can we, on top of stable RAS blockade, as shown in the pooled analysis, reduce albuminuria? And now we see the importance of doing a dedicated trial. I told you that a pooled analysis, a meta-analysis, can only generate a hypothesis, is never approved. And here you can see 24 weeks of exposure to linagliptin versus placebo showed a placebo-adjusted reduction of 6%. And I can tell you that a lot of people were very, very disappointed. I must say, I was not that disappointed because this was expected, because only 24 weeks on standard care. But on the right-hand side, you can see that there is a trend in the reduction of albuminuria in those on linagliptin. However, this is not significant. Look at sub-analysis. Here again, I'm sorry that about number 1 in the middle of those yellow bars should be a line, and you can see that they all go on the left-hand side of and basically they are consistent findings throughout these variables. Now, this slide is very important because this shows the main result of the Marlina. And you can see on the left-hand side that there were more responders in those patients exposed to linagliptin. So and response was defined as more than 20% decrease. And you can see that non-responders, more of them on placebo. And that was a significant difference. So if you put one of your patients that have already standard care, RAS blockade, stable RAS blockade, put them on linagliptin, some of the patients will respond. And if you don't do that, more of these patients will progress. So this is a good news, although it did not show the 28% reduction as in the pooled analysis. But again, you have to always to do after a pooled analysis to do a dedicated trial to prove something. And if you look at the next slide, this is also interesting because if you look at progression to macroalbuminuria, there seems to be a trend to less people going from micro to macro. And if you look at those that regressed, you can see that there was a tendency to more people regressing. This slide and the previous one, no significant difference. Again, what I'm saying that we are dealing with only a short period of time, 24 weeks on stable RAS blockade, and still we see a trend. So in the early signs of diabetic kidney disease, because albuminuria is representing early signs of diabetic kidney disease. And the question then arises, is linagliptin really expected to show differences in the early signs or at the late stages? I will come back to that in a while. So I have also to tell you that in the Marlina trial, linagliptin was very nicely tolerated by the patients, so we had no more adverse effects than in the placebo group. So it's a well-tolerated medication. Conclusions from the Marlina trial, I will make it short. I would say here that linagliptin improved glycemic control, 0.6%, and that was exactly the same result that we have seen in so many studies so far. So linagliptin is effective in reducing A1C. The reduction of albumin excretion rate was not significant, but there was a trend. And if you look at the data, more patients actually responded with a decrease in albuminuria than an increase, and that was significant. So there is a sign that something may happen. And then I asked the question, what did we expect? Because the experimental data that I will very briefly go through in the next is that the effect that we would expect is more on the antifibrotic side, and that would not be seen as an effect on albuminuria, more an effect on the eGFR. So there is one very important trial that you should watch out for, and that is the Carmelina trial in patients with type 2 diabetes, much longer follow-up than the Marlina, and that might show some effect. So let me show you briefly one slide from a very recent trial called the LEADER trial from a GLP-1 agonist. The reason why I'm showing this trial is that GLP-1 agonist and DPP-4 inhibitors, they work with a very similar mode of action. Now, LEADER trial showed that there were less macroalbuminuria, doubling of serum creatinine, people ending up on dialysis and having renal events. So it seems to be effective using a GLP-1 agonist. So what about then DPP-4? Now I will show you a few slides, experimental data. These are not from humans. I apologize for that, but it just highlights what can be expected in the future. Here you can see a picture on the left from a glomerulus, and you can see the brown staining. That's the preglomerular vasculature. And you can see that GLP-1 receptor is localized to this compartment. And now, if you give linagliptin to experimental animal, you can see here on the left-hand side, you have an increase in the GLP-1. And I just told you that a GLP-1 agonist reduced kidney problems. And now, if you look at experimental animal again, where do you find most of the DPP-4? Yes, in the kidneys. And this also busy slide shows on top on the left, DPP-4 is not expressed in a normal kidney. In the middle, you have type 2 diabetes. And you can see that now you see the red staining. So it's upregulated in kidney disease. And if you do more sophisticated data study, these are mice done in Japan. You can see if you give linagliptin to these mice, all the black bars in the middle are diabetes. So you can see that there is more fibrosis in diabetes. And when you give linagliptin, that is the beige bar on the right-hand side of all these, you can see you reduce that. So it seems that giving linagliptin to mice or rats, you actually reduce kidney problems. And this is the final experimental slide is shown here. Linagliptin-mediated DPP-4 inhibition ameliorates kidney fibrosis in diabetic mice. Look at the left-hand side top, normal situation, in the middle, diabetes, and look at the right-hand side, linagliptin, you can see that you reduce the problem. So what I would urge you to do, watch out carefully now for a study called Carmelina. Carmelina is a study on linagliptin in patients with type 2 diabetes. And these guys have, this is a FDA-mandated trial for linagliptin in the same way as TCOS was for sitagliptin, the allogliptin was the Examine, and then the saxagliptin, the Sabotini. This is the FDA-mandated trial for linagliptin. But what you can see, it has not only a cardiovascular endpoint, it also has a renal endpoint. And this will be very interesting to see the data in a few years. And if you can see this very busy slide, all the cardiovascular outcome trials out there at the moment. On the right-hand side, on top, you can see Carmelina, and it seems to be out in year 2018. So this is patients with long exposure to linagliptin, and I'm pretty sure that if linagliptin is preventing diabetic kidney disease to some extent, that will be shown by the Carmelina. I'm confident, based on the effect on the LEADER trial and based on the experimental data we have for linagliptin, this will come through. But dreams, we can have dreams, but we also have to show that the dreams come true. So Carmelina will be the step to do that. So dear colleagues, a few take-home messages from this presentation. First of all, diabetes is associated with an increased risk of cardiovascular disease, a remarkably shortened life expectancy. If you have type 2 diabetes and diabetic kidney disease, then you will have an even more increased risk of cardiovascular events and premature mortality. Intensive glycemic control reduces the risk of micro and macroalbuminuria, as well as risk of ending up on dialysis. Very good news, but we know that implementation of aggressive glycemic control has been problematic because of the risk of severe hypoglycemia. Now we are in a fantastic situation. We have a lot of newer medications that do not carry the risk of severe hypoglycemia. So today I focused on linagliptin, which is a unique DPP-4 inhibitor. It's unique because it's the only one that is not excreted by the kidneys, and you don't have to bother about adjusting the dose. You can give to any patient with type 2 diabetes. You can linagliptin, it's effective, it's a sustained effect, and we hope that we also in the future can show that it will have effects on the kidneys. So linagliptin may confer renal protection. All the Marlena trials showed only a trend to the reduction in albuminuria, but as I told you, some patients responded, and more patients on placebo progressed in terms of their kidney disease. So finally, Carmelina will provide the answer whether linagliptin is protective. Unfortunately, I cannot give you the answer tonight, but I'm confident that we will see we'll get good news for the future. So that said, thank you very much, India, and for giving me the chance. So WebRx for giving me the chance to talk about linagliptin, the role of linagliptin in the treatment or management of patients with type 2 diabetes. And I think this is very good news for the future, because by the newer medications, we can avoid the really big problems with severe hypoglycemia. And I do hope that many of you will also be able to use these medications in the treatment of your patients, because we don't want to do harm to our patients. We actually want to treat our patients to the best of our abilities. Thank you.